Welcome to Lovesick, the podcast, where we dive into health, wellness, and relationships and their impact on the world. Come be a part of the discussion. Join our community by following us on YouTube, Instagram, and listening wherever you get your favorite podcasts. Enjoy the show.
Welcome back, everyone, to our podcast, Lovesick Podcast. I'm your host, Dorothea McGuire, and to my left,
Jada Ford.
and today we have Dr. Essam Taymour, and he's a board-certified gynecologist in Long Beach, California. Welcome.
Welcome.
Thank you for the invitation. It's an honor to be here. I accepted this invitation because of the really importance of the topic. This is a very, very important topic. We are getting older. The average life expectancy is increasing. Women expect to live a very long period of their life in menopause, and that has ramifications. And the current healthcare system is really not allowing the woman to access the care that they need for that part of their life. This is a subject that is wrapped in controversy. I was fortunate to have practiced gynecology before 2002. And then in 2002, when the bomb dropped on hormonal replacement therapy, and we will talk about that, and then the impact of that on women's care as a result of that study, and where we are today. We'll talk about what our understanding of menopause is, or has been, and what it is today. So thank you for the invite again.
We are so happy that you're here. And now that you said the word menopause, why don't we get right into it? And Dr. Taymour, please tell us, what is menopause?
Well, it's a natural phenomenon. It's part of aging. When I went to medical school, they told us that menopause starts when the ovaries or the follicles in the ovaries stop functioning. The follicles, it's what produces a hormone called estrogen. And then there is a deficiency or a decline in the estrogen level in the woman. And they stop having a menstrual cycle for a period of 1 year. And that's what we call menopause. Now, so it is the cessation of menses for a period of 1 year, for excluding any other reason for that cessation being psychological or pathological. So the average age of menopause in the United States is about age 51, 52.
Oh.
Yeah.
Interesting.
Wow. And with that being said, what are the changes that actually happens to our bodies, Dr. Taymour?
So the road to menopause starts a little earlier. So it's a period that we call the perimenopause. And, and
she knows why I'm looking at her.
I don't know if I'm there yet, but maybe, I don't know.
and that can go back maybe 10 years before menopause sets in.
Oh,
There you
okay,
go.
there it is.
Yeah.
Interesting.
So our understanding today is that perimenopause is basically the woman would have the same symptoms: hot flushes, night sweats, fatigue, decreased libido. But when we test them with blood tests, the test comes back normal. So there is a test called FSH, and when we run that blood test, the values come back normal. You'll get a call from the doctor saying you're not in menopause. So why am I complaining? Well, we really don't know. You might have something else. So the current understanding now, and this is something new, because since we've learned that menopause is just an estrogen deficiency, it turns out that women produce a lot of testosterone
During menopause?
in their lives. In their lives.
Wow.
And actually, the average woman produces probably 4 or 5 times more testosterone than they do in estrogen.
That's interesting.
That is.
And testosterone in the body comes from 2 sources: the ovaries and the adrenal glands. And what happens in the mid-40s is that the adrenal gland starts to slow down, and the woman with testosterone level would drop.
Okay.
And the testosterone, that's before the estrogen level drops.
Okay.
And the testosterone deficiency symptoms are basically the same as the estrogen deficiency symptoms.
Okay.
The hot flushes, the vaginal dryness, the anxiety, the
Oh, that's
fatigue,
me.
the muscle pains,
Yes.
the joint pains, the brain fog. All that is so. It turned out that our bodies and women's bodies have estrogen and testosterone receptors throughout the body. And that's not an accident. I mean, if the testosterone receptor is there, it's there for a reason.
Right.
So when the testosterone drops, the women will start to complain of these manifestations that they think they're menopausal, but the blood test says they're not. And then they get diagnosed with depression, they get diagnosed with fibromyalgia, then they get diagnosed with autoimmune conditions, when basically all they need is hormonal optimization, which could be testosterone supplements.
Wow.
Huh.
This is the first I've ever heard of
Yeah.
that.
Well, I've been so I thought that I had some kind of issue, and I did get blood tested, but they were like, "You don't have early menopause." But I'm like, "Okay," but I don't know.
So yes, there is no good test for perimenopause.
Got it.
So you have to go by these symptoms.
Okay.
So, so menopause can come early and can come late.
How early?
So if it comes early, between age 40 and 45,
That's my age group.
That's you.
that's of concern.
Oh.
Because now that person is going to live 5 or 10 years more in their life in menopause or post-menopause.
Wow.
So we call that menopause and beyond. So you're going to live in the beyond for, instead of 30 years, you're going to live for 40 years.
With the symptoms, you're saying?
No. So the symptoms will come and go.
Okay.
The hot flushes and the night sweats and stuff like that will come and go. But there are consequences to living in the body with low hormone levels for an extended number of years. So, so that is, so I walk into an exam room every day, and I ask patients if they have any signs or symptoms of menopause, and they says, "Oh no, that was 2 years ago," and now I'm okay. Really?
Now it's done.
You like the way they diagnose themselves,
Yeah.
right?
So that person does not understand the downside to being low on hormones for the rest of her life.
Right.
Okay.
and that risk is significant. And there are many risks. They are running the risk of osteoporosis. They're running the risk of cardiovascular disease. They are running the risk of sexual dysfunction. They are running the risk of dementia. So all these are long. We identify them as old age disease, but the stage is set
Right.
at menopause.
And that's not old age.
Yeah.
I know,
That's
and that's
not old
like,
age at
wow.
all. Yeah.
So
Wow.
That's pretty.
uh,
I did not know the dementia and all that stuff. Like, I did not know.
so the long-term consequences are really significant, and and here comes the problem with our medical way of delivering care is because the physician really doesn't have the time to sit down and tell this person who thought that she's over menopause that she is at an increased risk for so many conditions,
Wow.
and that perhaps initiating hormonal replacement at that particular time, that what we call the window of opportunity, would decrease her risk for all these conditions. So
Like, this is
This
very
is definitely
interesting,
some
yeah.
new information. Also, I was just wondering too, what are the choices when people find out that they may be perimenopausal
Or
or
menopause.
menopause, like medically or holistic, holistically.
so when they do that, so there are the women will go first to the holistic things.
Mm-hmm.
So they will say, I'm going to lose weight, I'm going to stop smoking, I'm going to stop drinking, I'm going to go have some acupuncture, I'm going to go some hypnosis.
Right.
Right.
That sounds like some of the things we might.
Yeah, I'm going to take vitamin D and calcium.
Right.
And then some physician will give them a little antidepressant, and then sometimes an anti-seizure medicine called gabapentin. The question is, do all these measures work? Not as well. Menopause is a hormone deficiency, and the mainstay of the treatment is hormonal supplementation.
Okay.
So as I entered this business, the only hormone that we were giving was estrogen.
Which I used to take years ago.
Correct.
You did?
And
Yes.
Yeah.
Yeah.
today, we're giving them both, testosterone and estrogen. Now,
So,
this is
wow.
this is a new movement. It's gathering strength. It is not the standard of care yet,
Okay.
but I belong to a growing movement that believe in supplementing testosterone as well, and because we know that there is a significant deficiency in both hormones. But this is again not a standard of care today,
Sure.
and but I think in a very short period of time it might be. I was yesterday at a meeting for menopause, and I think the providers across the country that provide this newer treatment are now in the probably 5,000 or 6,000. So it is a gathering momentum, and eventually somebody is going to take us seriously.
Well, we definitely need to take it seriously. I mean, back in the day, I had estradiol. Remember, I had mentioned
Correct.
that to you, but
I
nobody
didn't even know testosterone was like a
you
thing.
just took the
like,
words out of my mouth.
Yeah.
Like who knew? Like
Yeah.
I don't think back then they definitely didn't know about the testosterone and the estrogen.
This is a new
Yeah.
new movements, and in practice. So I've practiced when we were just giving just estrogen,
Mm.
and the women felt good, certainly fine.
Right.
Today, it's they feel great. It's a difference between good and great.
Right.
Yeah.
Is
Yeah.
that great because they're getting two?
Correct.
Okay.
Correct.
So, yeah.
So yes, they have the energy, the libido, the
Yeah.
stamina to work out. The brain fog is better. Many of these
Right.
symptoms are certainly uh, being addressed
Mhm.
in a better way.
How does the medicine like affect like cancer patients or
So that takes me to the story of estrogen.
Mm.
It's a long story. It's uh, it's something that was isolated in the 50s, I believe,
Mm.
um, and uh, there was a book that came out in the 50s called Feminine Forever, and women read it, and it was give me that stuff. Hmm? Um, but then doctors prescribed it in high doses,
Oh my goodness.
and that led to women developing cancer of the uterus.
Mm.
And then they said, well, no, we don't want that stuff.
This is, wow, yeah.
So the doctor said, no, we have a way to mitigate that, and if we can give you some progesterone on top of that, then we can
Right.
quieten the uterus down, then you can continue to enjoy the benefits of estrogen. And that was okay. And up until 2002, um, estrogen and progesterone treatment was the mainstay of managing menopause.
Mhm.
And we have data, abundance of data, that told us how great that is. It reduced the incidence of cardiovascular disease by 50%. It reduced the incidence of colon cancer by 50%. It reduced the osteoporosis fracture by 50%, the dementia by 30%. You even lived 3 years beyond your life expectancy if you were a user. To the point that I believe in the 90s, one time the New England Medical Journal wrote an editorial saying, with all this, it's time for action.
Yeah.
It was like accepted practice and results. But then, but these were retrospective observational studies. That means that when the people that ran the studies would pull 100 charts of people that are using hormones,
Mhm.
and would ask them certain questions, and then they come up with a statistical assessment.
Right.
But that got people thinking: um, is estrogen making women healthy, or are healthy women taking estrogen? So, and they said, well, we have to sort out that thing and do what we call prospective randomized studies. That means that we recruit uh, uh, women
Mhm.
at the start of the study and give them the hormonal treatment and monitor them over a period of time. And that was the study that we call the WHI, or the Women's Health Initiative. And it was a massive study.
Mm.
It cost $1 billion.
Wow.
I mean, it was massive.
Well, $1 billion
Yeah.
is massive.
Well, I mean, it's
But-
everybody's going through it.
Right.
It's like,
So-
yes.
you know.
Yes.
but
I agree.
so the WHI is what destroyed all the good news that we had
Wow.
before before it came out. So it came out in July of 2002, and it came out in a very dramatic way. And they intended to bring it out in a dramatic way. I mean, it was a news break on ABC.
Oh.
Stop the presses. Women that are taking estrogen, you're in trouble.
That was me. That's what they
How
said.
long were you taking it?
Oh my gosh. I was taking, remember we talked about, I said estradiol.
What's
And
the difference?
well, I was just taking estrogen when I was in my 30s, a long time ago.
Before you had the hysterectomy?
Before I had the partial
Partial
hysterectomy, when I had that when I was like 42.
Okay.
So, but then after taking it, that's when they told me, oh, you shouldn't take this past 5 years. I'm like, what do you mean? They said if you take it past 5 years, you increase your cancer risk by, so high. And they actually took me off of it. And then they put me on something else. I believe it was Synthroid.
The Synthroid is a thyroid.
No, not Synthroid.
Yeah.
It was something else that they gave me in place of the estradiol. And
Nothing with testosterone.
But nothing, yeah, well, I don't know if they was even doing that back then because I was in my 30s. Like I'm 65 right now.
So at the time when they did the WHI study, the hormone that was in use was something called Premarin.
I've heard of that. Yeah,
And
you wouldn't know.
and,
Nope.
and the name Premarin comes from pregnant mares.
Oh,
So they extracted what they called conjugated estrogen from pregnant mares. The WHI had two arms to it. One arm, they were giving just straight Premarin to women that had a hysterectomy or didn't have a uterus. And the other arm had people taking something called Prempro, which is a combination of Premarin and a very powerful progestational compound called Provera. And it was in that branch of the study that they looked at breast cancer and cardiovascular risks and dementia, and they found that the relative risk for breast cancer was 1.26. Now, a relative risk of 1 means that we're okay, one way or the other. 1.26 they interpreted as a 26% increase in breast cancer. But that number is deceiving because 26% means the difference between 5 in 100 and 6 in 100.
Oh, true. Yeah.
right.
Okay?
Yeah.
So in their calculation, they said that for women taking this Prempro, their risk for breast cancer increases to the degree of 8 patients for every 10,000 users. So it's a very, very small risk.
Right.
But the people in the study were so hypersensitive to any increase in breast cancer. The increase in the study did not, they said, even in their own words, they said it almost reached statistical significance. Well, almost means it didn't.
Right.
Right.
It didn't happen.
It didn't.
Right.
And when they updated their finding, the study went on for years, and when they updated their findings in 2000, I believe, up 3 or 4, they came out and said it barely reached statistical significance. What barely means still didn't.
Right.
And in 2006, on another update, they finally said there was no statistical difference. So the people that rang the bell of fear in 2002, and it's still resonating with us today, retracted that. but it was retracted on page 30B in the New York Times. Nobody read that. So,
Wow. This is some really good information.
now, the branch of the study where they used just Premarin, which is an estrogen, alone with no Provera, the relative risk was 0.77. That means that it was even less.
Yeah.
It was
Right.
protective.
Mhm.
But the way they came out and told the public about the risk, it's still resonating with us today. So when I talk to a patient in an exam room and says, we're going to put you on estrogen, what she heard is, this doctor wants to give me breast cancer.
Right. Okay.
Not only that, but she's going to take that prescription and go to the pharmacy, and the pharmacy is going to give her the hormone and another sheet that says, are you aware that your doctor is prescribing something that is or might cause cancer?
Right.
And if we pass that hurdle and she takes it home and she meets her neighbor, and her neighbor
Nosy Betty.
and Betty will tell her, are you sure you want to take this? I heard it causes cancer.
Right.
So today, out of all the candidates that need hormonal replacement, I believe the last number I heard that in America, less than 10% use it, maybe less than 5%. I mean, it's a disastrous number.
Yes, that is.
Because we just cannot get beyond that fear.
Yeah, true.
So if you are to ask the question, does estrogen cause breast cancer? Well, the WHI initially said yes, but then they retracted it. But then you have to also say breast cancer is a disease that increases in incidence as we get older. And as we get older, the estrogen level is not increasing, it's declining.
Right.
Yeah.
So how do you reconcile and you're attributing a disease, a cancer, to a hormone that's declining, not increasing.
Right.
The same with testosterone. Testosterone is declining, and the cancer is increasing. And we're going to talk about really testosterone being protective against breast cancer. So how do you explain the fact that in women who come down with breast cancer and they happen to been using hormonal replacement, if they were, their outcome of treatment is by far better than if they were non-users.
And I was going to ask you.
That's what I was.
Yeah,
You were going to say, Paige.
Well, not only that, if breast cancer patients can use HRT.
So today, I think the science is in one place and the practice is in another place.
Okay.
So if you go to the oncologist, they will say absolutely no. Okay. Yeah. So where'd they come with that answer? So I can cite you 15, 18, 20 studies that says there's no difference in the recurrence if you take hormonal replacement, estrogen, after breast cancer,
Right,
or not. Even the FDA in the early 90s have wanted UCI to run a study, but it didn't happen. But the oncologists today that I work with are in agreement that we can give these women testosterone, and particularly with an estrogen blocker. So, and I'm happy with that until the tide changes. So on one side you have 20 studies that show no difference,
Right.
and then there is on the other side there's one study called the habit study, and they're all hanging their hats on that study that shows a slight increase in the recurrence of breast cancer in women that are using tamoxifen in addition. So,
I've heard of that.
So, but the fear is nobody wants to.
I mean, I can
Go
see
there.
the fear because all the information, and I know that different sources, but to me it seems like controversial. You know what I mean?
Well, it's also like I want to know like what the risks are if I am going through menopause and then I'm like I don't want to take anything. It's like
right.
it, you know.
So powering, many people will tell you, I'm going to power through it. Well,
Say good luck with that.
at the expense of coming down. So initially you're going to be all right, but 10 years out, 15 years out, now we're talking about a whole different situation.
Yeah.
So like osteoporosis, let's go there because the hormonal replacements protects you against osteoporosis. You reach your peak density when you're age 30, and then you slightly decline, and then the bone density precipitously drops actually before you enter menopause, like a year before, and continues for 2 years after, and then it continues to decline. Well, that condition impacts 1 out of 7 women.
Osteoporosis.
Osteoporosis.
Wow.
Jeez.
50% of them are going to have a fracture.
At what age?
Well, we're talking probably in the 60s, 70s.
Yeah.
Because they have bone density.
Yeah.
Yes.
And
I've had that.
And out of the 50% that are going to have fractures, a third are going to die. So the risk of dying from a fractured hip because of osteoporosis, because you did not want to go on hormonal replacement, is the same as breast cancer.
Man. No, this
God.
is like honestly, this is very interesting because as a person who's learning more and more about this, it's you know, I was under that whole impression like, okay, well, my period will just be done and then
Right.
I'm just
You're
gonna
free.
be sweating out and then I'm good. You know, like you just don't
You're
realize.
liberated.
Yeah, you're liberated. Not menstruating anymore. Like it's like
I'm done.
that's but there's so many other things. Yeah.
Imagine what I felt when I got the partial hysterectomy. I was like, yay!
And now you're like,
No
now,
more menstrual cycles. But then on the other hand, all the other
Now,
symptoms.
if you want to take it to dementia,
Let's
which is
take it.
That's
there.
the part that
the WHI said the hormones are going to increase dementia, contradicting all other studies
Wow.
that said that hormones estrogen in particularly will protect against dementia to the tune of about 25 to even 60%.
I didn't know dementia was on the table.
No, I did not.
So,
Yeah.
so that really should take us to the WHI because these people have just undid what we've known all along.
Mm-hmm.
And the reason the numbers came out this way is they told us that the patients that we are recruiting are representative of the general population. Was it? No. Their average age in the women that they recruited were 63, 10 years out into menopause. 30% of them were obese. Another 35 or 40% were on blood pressure medications. Another 50% were smokers or ex-smokers. So these people that enrolled in that study came into the study with serious pre-existing conditions
Yeah.
that set the stage for them to have complications that skewed
Yes.
the results. So,
Ugh.
so that's our critique of the WHI. Yeah.
That makes. I mean,
So what about the let's go there since you talked about sexual. How does menopause affect the quality of life and especially the quality of your sex life for partners out there?
Okay. So the hormonal deficiency is going to impact everybody going forward. So you stop your periods, the hormone levels drop, both estrogen and testosterone. It will lead to physical changes in the in desire, in libido, in
Body weight.
in
yeah,
That
changes
too.
body weight.
Yeah.
in vaginal dryness,
Okay.
in pain with sexual relations,
Mm-hmm.
in bladder problems, in um, um, so the women will have a challenge
Right.
having sex because some people will tell me it's like broken glass, doctor.
Ooh.
Wow.
Oh my
Uh,
gosh.
and the thing about this, we call it the genitourinary syndrome of menopause because it's a constellation of symptoms and signs that pertains to the bladder and the vaginal canal and the vulva. So the, the the thing about it is progressive. That
Mm.
means when it starts, the next year it's worse, and the following year it's worse still. It doesn't get any better by itself, and
Jeez.
and it needs treatment. And people have used moisturizers and lubricants, but those are band-aids.
Right.
So there's a physical change that happens in the lining of the vaginal canal. The skin of the vaginal canals becomes thinner. The ecosystem in the vaginal canal changes. We have ecosystems in our what we call microbiome in our intestines, and we have a microbiome on our skin. We have a microbiome in the vagina. And the microbiome in the vagina has to be in harmony and balance to prevent infections. And when the vaginal dryness sets in,
Mm-hmm.
the woman is vulnerable to infections, both vaginal and urinary. So they come in with frequent urinary tract infections, and the urologist would keep giving them antibiotics, one antibiotic after the other.
Right.
When the source of the infection is the vaginal canal seeding into the bladder.
Mm-hmm.
So, so that the treatment really has to be well, we have two treatments now. One is hormonal, which is giving them vaginal
Okay.
estrogen.
Mm-hmm.
And in the last 10 years, something came about, and it's a laser treatment.
Oh,
Uh,
technology.
Technology.
Yeah.
So it's kind of like when people go to see their plastic surgeon to get a facelift, and he says, "Oh, it's a non-surgical facelift. We're
Right.
going to use a laser playing on the face, and that will build the skin up."
Okay.
Well, the same technology is now adapted to treating the vaginal walls. It's a fractional CO2 laser, and the company named the machine Mona Lisa. It's a treatment done in the office. It's not painful.
Okay.
It's done under the local anesthesia. The patient requires about three treatments.
For it to be successful.
Yeah, to because in every treatment we use different settings.
Okay.
Does insurance pay for that?
I was just keep taking all
we
my
think
words.
about this.
I was literally
mother
gonna
and
say
daughter. See,
insurance on that, but also on top of that, the like hormonal medicine and everything,
Right.
like all of this.
Not many insurance don't even cover hormonal.
wow. So that is out
Medicare
of
doesn't
pocket.
cover it.
Wow,
Oh, that's a
So-
whole other thing.
that's a
right
whole
there.
nother show right there.
Yeah, right. But the answer is no.
They
do-
don't
They
cover.
do not.
That's like an
cover it.
elective.
So yeah, so it's like they don't consider that being something that's necessity.
Correct.
Okay, that's just pretty much like when you get
Elective or
the
something.
elective surgery or whatever.
Correct. They
But
look
even with
at-
the medicine, even with the
Yeah.
hormone and testosterone, like
Yeah,
wow.
I mean, what's the role of
Testosterone.
testosterone?
Testosterone.
so,
I was like, da-da-da-da-da.
Sorry.
so right now there is a condition called the hyposexual desire syndrome.
Okay.
And testosterone
You just
can be used for that.
I'm sorry, I'm not laughing. I'm just me getting the
She can't.
Oh, you
Okay.
make testosterone just like men.
Yeah.
Okay.
But testosterone is very good to bring back libido and desire and orgasm.
And so people have to pay for that, though, right?
Yes.
Yes.
So
Jeez.
testosterone is not a covered
Right.
benefit.
Mm.
And the way it's given today, it's in the form of a pellet.
A pellet?
Pellet, yeah. Pellet is like a grain of rice that we put under the skin,
Oh.
and it's done in the office under local anesthesia. So the people that choose to be on a combination of estrogen and testosterone,
Mhm.
they come for what is called the pellet treatment,
Okay.
and it's
And how long is something like that? Like how often? Do you
so
have to...
it lasts for about 3 months.
Okay.
Wow.
and-
So every
and-
3 months?
And the pellet treatment is very good because of where the pellet sits and the absorption. So the absorption from the pellet is steady.
Okay.
More steady than a patch, more steady certainly than an oral pill, more steady
Mhm.
than an injection. So you don't have the up and down fluctuation of the.
And where's something like that inserted in your body?
It's in the upper buttock.
Okay.
Where there is,
All right.
there-
Skin.
and
Okay.
and sometimes on very skinny people we put it in the front and wherever they're.
You need
Yeah.
some fat
some meat.
there.
Yeah.
Just go ahead and say it, Dr.
Yeah.
Taymour.
Yeah.
You need some meat there.
What are your thoughts? I have a question. What are your thoughts on, I get a lot of, I guess, when my phone's listening and social media stuff that comes up, but like all of these, you're going to gain weight when you go through menopause. Here are these vitamins that'll, keep you from gaining all the hormonal weight and stuff. What do you think about that stuff?
Well, women are very sensitive to weight.
Yes.
Yeah, I mean that
Yeah.
goes without saying. Well, there are metabolic changes that happen around the time of menopause. There's no question.
Mhm.
Lipid changes that happen around the time of menopause, and those changes lead to cardiovascular risk. So the testosterone, the people that opt for the testosterone tend to have the testosterone increases muscle mass,
Okay.
Oh.
so at the expense of fat mass,
Mhm.
and they tend to be more have more energy, and they can
Perform.
whatever workout they
Right.
do
Yeah.
will yield results.
Okay.
What are those side effects? Like, am I getting a mustache?
Uh,
Like, I'm being
Yeah, but
serious,
that's
but that's
true.
the testosterone. I'm curious.
Yeah.
everybody asks the same question.
I'm sure.
Yeah. I mean, because when you're saying testosterone, you're thinking men. Like, I think about male counterparts. You know what I mean? It's like, okay, what is that going to do, like
Well,
Jada said,
uh,
to women?
well, we monitor that,
Okay.
and if we are to overshoot, there will be some skin changes and acne.
Like a mustache or
Now,
something?
But skin changes.
sometimes hair growth in some places. But if that happens, you just readjust the dose, and that can be corrected.
Okay.
Now, men come for testosterone supplements, but just to give it give you a little conceptual difference,
Mm-hmm.
a male sometimes will need 1,500 milligrams of testosterone. A woman is going to need 100.
Okay.
Uh,
Okay.
Got it.
Yeah.
so
makes
that's
Mm-hmm.
Okay. Okay. That
Yeah.
makes sense.
So how is it best? How is the HRT best administered?
so. It depends on the HRT that the woman is going to choose. If
Mhm.
she's going to choose the estrogen progesterone
The combo.
combo,
Mhm.
if she has a uterus, or the estrogen alone. If she
Mhm.
the progesterone is given orally, there is no other way to give
Okay.
Is
it.
that how you were taking it?
I wasn't taking progesterone.
Oh, you were taking
I was
it.
only taking estrogen,
Yeah,
Oh,
because
which
okay.
was orally
because
also.
you had a hysterectomy.
It
they-
had a
Oh.
partial,
So they
That's why.
because I still have my ovaries.
Yeah, that's fine.
Yeah.
But the thinking now is really to stay away from the oral hormonal replacements,
Mm.
Why is that?
because anything that you take orally is going to go to your stomach, it's going to go to your liver, it's going to agitate the liver and produce inflammatory markers. It
Okay.
increases the risk for clots.
Mm.
It increases, the liver starts to produce some protein called sex binding proteins, and they attach to the hormones and they make
Oh
it
my
unavailable.
gosh.
So the thinking now is to kind of go around the liver, and that would be with patches, with gels, with pellets,
Mm.
vaginal creams. So that would be the route of preference.
Right.
But nothing like injections or
Um,
anything like that.
no, the injections are kind of tough because of the the blood level is going to jump up, and
True.
so the you want a steady
Right.
a steady.
And can injections like affect the organs in some kind of way if you're trying to get around certain organs?
I'm not sure what you're.
Like you were saying, the injections, it can make maybe the blood, I guess maybe your blood pressure or something.
Well,
go up.
fluctuation in hormones will drive you
Okay.
crazy.
Yeah.
Yeah.
Yeah. So you want a steady
Mm-hmm.
level, and a steady level allows us to monitor that. We like to get a fasting blood level
Mhm.
for the hormones in the morning, because it's impacted by diurnal variation. So we want to set a standard, this is the time of the day when we're going to measure it,
Mm.
and
Yeah, because my hot flashes are off the chart. Like when I get mine, and I still get them.
I was gonna ask if there's a world where they
Yeah, like
start
when
simmering
does
down.
it stop? Like when does it, like she said, simmer down? Because when I get these hot flashes, they are intense, and it literally stopped me in my tracks. I can be doing anything, having something. I'm like, oh my gosh, wait, and then all of a sudden have that
You're
anxiety.
in your
so
60s.
so you
Interesting.
Yeah,
you are on estrogen currently?
I'm not on anything
Yeah.
now.
Yeah.
Yeah,
Well, I mean, you have a reason to be on something.
I know.
That's why I'm like, whoa, you should
No,
be on
you're
something
right. I
now.
mean, with the anxiety,
Yeah.
honestly, you're right.
So the anxiety is more of a testosterone issue,
Mm.
because the testosterone is an anti-anxiety. So some people, when they start the the testosterone treatment, they get off their antidepressant and they stop the SSRIs.
Mm-hmm.
Um,
What's
yeah,
SSRI?
the Prozacs. And,
Oh, because I
yeah,
was like, what is, okay,
yeah,
all righty.
yeah.
Hmm.
Wow.
Well, that's good to know because I haven't had the therapy in so long. And, I do have high anxieties at times and, with the flashes and everything else. And, I was wondering, when does this stop? Like, what age do you really start to see it kind of decline a
Well,
little?
your case is unusual.
Oh,
Uh,
how
but
unusual.
most of the hot flashes
Really?
will subside fairly quickly, but
Not mine.
some will linger for 20 years.
Wait, 20 years after what I am right now? Jeez.
I'm sure it's not a one size fits
Oh my
all,
gosh.
but
Yeah.
Are you serious? 20?
No, some people. I have patients in their 70s and 80s, and they still have hot flushes, but
Oh
not
my
very many.
gosh.
Most
Yeah.
most of them, like the patient I described early on in the discussion, are you menopausal? And says, yeah, I went through that already,
Right.
I'm already
Yeah.
done.
and I'm already done.
I do have a question though, and I know this is not about menopause, but I know there's a controversy also about how often a woman should go to the gynecologist for pap smear.
Well, we
Yeah.
stopped doing pap smears at the age of 65.
Okay.
And if the pap smear has been normal all along,
Right.
we don't do it more often than every 3 years.
Okay.
But if the person had an abnormal pap smear at some point in time,
Right.
then that requires an annual
Okay.
evaluation. And
Well, that's some good clarification because
yeah,
mine has always been normal since I've
that's
had them. But now I'm at that age, I'm like, wait, the GYN's like, well, the insurance, they don't pay for it unless it's X amount of
I was gonna say, is it
years.
3 or 5 years?
Because I've been hearing different stories about it.
well, the insurance has to pay for it if it's indicated.
Okay.
Okay.
Yeah, I mean it's just
Right. But so 3 years,
uh,
because I was like, do I get a pap smear
yeah.
now?
Now
Because,
you're
Uh,
65.
but now I'm 65, like, do I get
but
one?
but a woman needs an annual exam for many other reasons.
Right. I get my
Because even when you get a
annuals.
physical, though, you still get some of, it's not a full on. Well,
Right. I get the annuals and they do, like you said, they do the breast exam and all those kind of things too. But I was just thinking, I'm like, when do I go back now to the GYN doctor? Because now I'm 65 and they're like, no, you don't have to go. Or, if you had regular, what is it, test that you have for the past 5 or 10 years, you're fine. I don't know. I don't know what to believe.
The gynecologist has more encompassing job than just getting a pap smear.
Right,
yeah, of
right.
course.
Is there to assess your hormonal
Okay.
status, your if you have any ovaries, they need to be checked.
Right.
Uh, we check bladder functions.
Okay.
So
So basically, yes.
yes, the answer is yes.
Yeah. Okay.
Yeah.
Good.
Yeah.
All right. That's good to know because there was so much, and I'm like,
There's so much controversy.
it is. It's a
curious,
lot of
too.
controversy, but then I thought I've never gone that long for one, and so it makes you think like, wait, should I be actually going this long? Because when you're used to going to the doctors, like I do mine around the same time every year, and then that part of it is not, you're not going. I'm like, that doesn't seem right, that you don't go once a year, or now they're saying two or the third year. So now I got a little bit of clarity.
I just want to bring to your audience the condition of dementia because
Okay.
that scares a lot of people.
Yes, please.
Yes. Yeah.
And women are more likely 2 to 1 uh, as compared to men likely to come down with dementia. And hormones, contrary to the WHI finding, does protect women from that, and but they have to start early because hormones need a healthy neurons to protect.
So wait, is it too late for me?
The neurons are the nerve cells.
Is that too late for me?
Well,
You can go ahead and say it. I won't take it personal.
because if it's given once the diagnosis is made, then it doesn't slow it down and it doesn't eliminate it.
You need to be
and that condition scares a lot of.
It scares me.
Yes, it's more common than breast cancer.
Wow. So that means Jada should be maybe checking into those because she's at the age where she can get some protection. I guess I'm beyond the protection now.
Well,
but
I mean, I'm one of those people that sit in the camp that says hormonal optimization is really key to a healthy life.
I can see that.
In the menopause and the beyond.
Okay.
And it's a critical part. I mean, it's not the only thing, but it's a critical part of it. Yeah.
Wow.
That's definitely be looking into.
I mean, that's good to know and good for the viewers and audience to know because I would have never connected dementia with hormonal treatment.
Same.
I mean, I just wouldn't have. I just thought of that as a separate illness, something that people get sometimes as they get older and it slowly comes on, like an onset of it. But I did not know that there was some type of protection that could actually help women before they even get to that point.
Yep. So I want to bring to your audience slides.
Okay.
That will help them calculate their breast cancer risk.
Okay.
So in general, your doctor will tell you that your risk of coming down with breast cancer is about 1 in 8 over a lifetime. But that doesn't help you out.
No.
So there's this study that broke it down by decades. And if you look at the decade of the 30s, if you're between 30 and 40, your risk is actually 0.4%. If you're between age of 40 to 50, it's 1.5%. So, and the risk keeps rising with age. So when they came out with that number 1 in 8, which means 12%, the 12% came by just adding these numbers down on the right column. So if I am to say you are now age 60 and you haven't had breast cancer before, your risk today is not 12%. It's not 1 in 8. It's 3.6 plus 4. It's 7.6%, which is less than. And if you are 70 years old and you haven't had breast cancer before, your risk is not 12% or 1 in 8.
Okay.
Your risk is only 4%. So I think the viewers need to kind of break it down by decades to know where they stand and to accept hormonal replacement. So one thing I can tell you, viewers, is the great majority of women that came down with breast cancer never used hormones.
You would think that's the other way around.
Correct. And a great number of people that use hormones will never have breast cancer.
Oh my gosh.
I feel like you get fed the other way around.
Yeah. But this is why you're here, because like you said, when you're in a doctor's office, you can't get this information.
No, we only have 15 minutes for you.
You can't, it's a shame, but we can't get this information.
This was fantastic.
Yeah, definitely.
unfortunately, our hour's coming to
Yeah.
an end. But man, we could talk all day because
Yeah.
this is very interesting, and I think
We
it
have to
needs a
have you
two-part.
back. We have to have you
You
back
back.
Well,
again.
Thank you for the invitation. I'm happy to come back, and I hope this would be beneficial for
Oh, absolutely.
people watching in assessing their own risk and choosing to be on hormonal optimization or not.
Yeah.
Um,
No, we appreciate it.
Yeah.
Before we go, Dr. Taymour, how can people that live in the Long Beach community or just anyone that's in California that's in SoCal that can get in
my
touch with you?
my office is here in Long Beach,
Okay.
next to Long Beach Memorial, and the phone number is 562
Mhm.
595 5331.
Say it one more time.
562 595 5331.
Okay. All right. Thank you so much for joining us on the lovely couch today to inform our listeners and our viewers. And we really do appreciate it. And
Well,
thank you so much.
Thank you
Dr.
again
Taymour.
for having me.
Thank you.
I appreciate it.
Thanks for listening and watching, everybody, the official Lovesick podcast. And we'll see you soon.
Bye.
Bye.